Hello, everyone. I'm Dr. Amit Kulkarni. I'm a consultant neurologist attached to Sagar Hospitals, Bangalore. So I welcome you all for my today's talk on headache, and also to some extent, I would like to cover a few aspects of neurological management. Um, so first of all, I think we all need to understand what is headache, and uh, generally what happens whenever you have headache. Some of the headaches are so severe that it would be nice if I could share the screen, but however, since I'm not able to share the screen, there are headaches which are so severe that it might even create suicidal tendencies. And so it's very important to understand the nature of your headache and to understand what is the type of headache. Invariably, what happens when people come to my clinic and say, "Doctor, I have a migraine." That's the first statement that is that comes across. And then it's very important to understand. I need to dissect out and say whether this is truly migraine or something else. And so what is migraine? So migraine is a primary headache disorder which is characterized by recurrent headaches that are moderate to severe. Typically, the headaches are one-sided, one half of the head. They are pulsating in nature. These two things are very, very important. So usually it is hemicranial, not always, but usually, and it is pulsating in nature. And it may last anywhere between 2 to 72 hours. That means a headache attack can last anywhere from 2 hours to 72 hours. What are the important things or features that suggest migraine? So one of them is associated symptoms like nausea, like vomiting, like sensitivity to light, sound, and smell. Pain is generally made worse by physical activity, and usually up to one third of the people tend to have some kind of an aura. And this is typically short period of visual disturbance that signals the headache that it will soon occur. So it's something that is giving a warning sign that the headache is going to start. But it is not always. Again, this is only seen in about a third of the people. And sometimes, rarely, an aura can occur with absolutely no headache. So both the things are possible. So then when we have a unilateral headache that is one sided, if you have a pulsating headache and you have a moderate to severe headache and something which is worse by physical activity like walking, climbing stairs, it is worse on going out in the hot sun. So all these are features which tell us that this is migraine. And whenever there is no aura, we call it simply as migraine without aura. And whenever there is aura, we call it as migraine with aura. Um, so what are these auras? So auras can be again multidimensional. There can be visual aura where somebody can see some kind of a bright light or some kind of moving spectra, what we call as fortification spectra. Somebody says they can see dazzling lights. Some people can see some kind of darkness coming from one field of their vision. There can also be sensory aura in the form of some kind of abnormal feeling or abnormal perception of sensations. There can be a speech or a language aura where they can have difficulty in speaking or understanding. Rarely there can be other auras as well, which are not very commonly seen. And usually it's at least one aura symptom is there, which gradually increases over 5 to 10 minutes. There can be multiple auras also, and aura is usually followed within 60 minutes by the headache. So whenever we find that somebody has got migraine with aura, it is more easier to treat in one way that they have a symptom of they have the aura. So it's something that is giving us a hint that there is something that we can give, what we call as migraine aborting agents. And whenever we give these migraine aborting agents, we tend to see that these headaches come down dramatically. And it's something like a boon at times, because by the time the headache starts, we can administer some medications which are called as triptans, or there are other various kinds of acute therapies in migraine. So these are all things which can help in reducing the headache attacks. And very commonly, compared to migraine, there are other types of headaches. That's why it's very important when somebody comes to the clinic to dissect out and to say that whether this is migraine or something else. So, in that, one very common thing, and even more common in today's stressful world, is tension type headache, what we call as TTH. And what does it mean? So, usually, it is something where they have kind of a band like feeling, like somebody has tightened a string around their head, and it's, or sometimes some kind of a heaviness which may be in one particular area, or sometimes fleeting. That means once it comes in one area, once it comes in other parts of the head. So something which is like a pressure or a band like sensation, and something that fleets. It's not always constant in a particular location. Commonly, people describe that they have bitemporal. That means they have dull, boring kind of pain occurring on both the temples. So this is again a very common finding of what we call as a tension type headache. Then what are the other things? That tension type headache generally does not have these typical features like pulsations or throbbing, and they also do not have this feeling of nausea or vomiting, and sensitivity to light may not be there. However, they can have this sensitivity to sound. So whenever there is somebody who's telling that their headaches are worse with noises or high decibel of sound, so these are again patients who can be migraine, they can be tension type headaches. So what differentiates the two is definitely the character of the headache, which I told you just now. It would have been good if I could be sharing the screen. I apologize that I could not share the screen. And this is something which again is very common, and whenever we see an outpatient OPD practice, we can see it very frequently. People having these kind of headaches, which is called as tension type headaches, and more so in today's time, when somebody probably having a risk of their job loss, or having staring down a financial stress. So these are all things where this kind of headaches take precedence. Now, apart from these headaches, like migraine, what I talked about, and tension type headache, so these are acute headaches, which I talked about. So people may complain of one headache attack that occurred today, the another attack that occurred a week later, or maybe a couple of weeks later. But then, more commonly, when these headache attacks increase in frequency, that means they become more and more frequent, and these lead to a condition what we call as chronic migraine or chronic tension type headache. So what does chronic migraine mean? Chronic migraine is something where the similar features of migraine are there, but the frequency is at least 15 days out of 30 days. That means almost half a month in 1 month, and for at least 3 months. So whenever these same attacks become more and more frequent, or become more and more chronic, having the same accompaniments that I spoke about, like throbbing feeling, having a feature of nausea, vomiting, aggravation with physical stimuli. So all of these things can be there in chronic migraine, as well as in chronic migraine. But then what happens there is that there is uh, increase in the frequency. That means it's a number of attacks that differentiate the two. So here what happens is this same headache occurs for almost 15 days in a month, at least 15 days, sometimes even 30 out of 30 days. So whenever we have a situation where there is headache attack occurring for so many days, for at least 3 months, then it fits into a thing called as chronic migraine. And similar thing when we say there is no sensitivity to light and sound, and then the same features that I spoke about, then we call it as chronic tension type headache. Now, these are two very common things, and it's very important to understand, these two things to differentiate the two. What causes migraine? So there are various theories, which tell us what is the real causation for migraine, and in that, commonly, there was an old theory which said a vascular theory, where it was because of the vasodilatation. That means the blood vessels in the meninges dilate and increase blood flow, and that's what causes it. There are more theories now which say that there is a spreading depression, cortical spreading depression that happens, and this is called as a neurogenic theory. And the third theory, which is what we say as neurogenic inflammation. So here what happens is we have our trigeminal nerve, the fifth nerve, which the nerve endings are in our face and in our brain. So whenever there is excessive stimulation of these trigeminal nerves, it leads to a release of some chemicals, what we call as 5-HT or 5-hydroxytryptamine, neurokinin, substance P, and CGRP. So all of these are chemicals which are secreted, and it is they which lead to the pain. So this theory is called as neurogenic inflammation. And invariably, either of these mechanisms lead to finally what leads to, it leads to a stimulation of the trigeminal vascular system, and that leads to pain in the distribution of the trigeminal nerve. That means along the face, it may be V1, it may be V2 or V3. So there's usually, as I said, neurogenic inflammation leads to a lot of these chemicals being secreted. And as I said, the important ones are substance P, calcitonin, gene-related peptide, and neurokinin. So, so this sensitization to these kind of stimuli are the real reasons why attack of migraine occurs. There can be also something called as allodynia. That means something where normally a non-noxious or something which doesn't cause pain can lead to a pain. That is called as allodynia. And there's something called as hyperalgesia. Hyperalgesia is something where there's increased sensitivity to painful stimulus. There is a painful stimulus, but that it leads to a higher degree of pain. So this is commonly described, in case of migraines. So there are various genetic hypotheses, and there are various genes which lead to transmission of migraine through the in the families. So common one of them are FHM gene, which we call as familial hemiplegic migraine, and there are various other genes like PRR2 gene. So these genes mutations also can lead to these kind of headaches. Now, apart from these headaches, as I already spoke about, we have some kind of trigeminal headaches, what we call as one of them is hemicrania continua. So here what happens is the characters are slightly different from migraine, and here generally people tend to have hemicranial headaches. They tend to have a half side half headache, but along with that, something's very important to remember is they can have unilateral, that means one-sided redness of the eye. They can have a nasal congestion. They can have a stuffy nose or running nose on one side. They can have eyelid edema or swelling of the eyelid on one side. They can be sweating or flushing of one side of the face. So all these can happen along with, in conjunction with the headache attack. And this again can be aggravated by movement. How do we distinguish between this and migraine? Is definitely, as I said, redness of the eye on one side, nasal congestion, eyelid swelling, facial sweating. So all of these autonomic symptoms, what we say, these are more commonly seen in autonomic headaches. One of them, as I said, is hemicrania continua. While these are not really seen in case of migraines. Then there are various other things like new daily persistent headache and various other types of autonomic headaches. So there is one very common and very crucial primary headache syndrome, which is trigeminal, is cluster headache. And you must have heard, or you must have, somebody in the vicinity, you must have has experienced this. So generally what happens is a severe pain that starts in the periorbital or behind the orbit, behind in the eyeball, in the eye socket region. And the pain can also spread from there to the forehead region. The pain is very, very severe and stabbing in nature. The pain usually lasts for about 30 minutes to 1 hour to 2 hours. And the pain is so severe that it can lead to sometimes suicidal tendencies. So these are very, very severe headaches. And again, they can have autonomic symptoms like redness of the eye. They can have sweating. They can have stuffiness of the nose, and all of these things can be there in these conditions called as cluster headaches. Now, why is it called a cluster? Because it occurs in clusters. It occurs whenever the headache attack starts. It invariably predominates. It usually occurs at one particular time of the day, and it usually keeps coming back at but that particular time itself. Sometimes it has a seasonal preponderance, like you can have these headaches occurring daily for say a month or two, and then the headache magically disappears without even giving any prophylaxis, and then again the next year around the same time it starts again. So this is something which is very classically periodic, and this is what is called as cluster headaches. Now, knowing the fact that we know that these are all primary headache syndromes, but how do we differentiate between those that are really serious and that need further attention, or these are ones which can be self-medicated at times at home, and you can wait and watch. So there are a few things which are what we call as red flags, and amongst them, some of the red flags I will just describe. Somebody who is more than 50 or 60 years of age having headache for the first time, always be careful about it. Acute onset thunderclap headache, that means the first serious severe headache without any history of headaches in the past. As I said, new onset headaches in somebody who is elderly. um, a significant change in the characteristics of prior headaches, like people having headaches in the past and the character of the headache changes. um, Whenever it's associated with fever, chills, or any weight loss, these are again red flags which should lead you to think about some kind of probable neuroinfection or something else which is causing the headache. Then you can have headache syndromes where they can have increase on lying down or increase on sitting up. Any change related to the posture is something that also can be a red flag. Any presence of neurological symptoms and signs. For example, along with headache, somebody has got giddiness, somebody has got difficulty walking or swaying while walking, or somebody has developed weakness on one side of the body. Somebody has developed numbness on one side of the body. So these are all things which should lead us to understand that this is probably not a simple primary headache syndrome, and we need to investigate it. That means to say that these are the people where urgently a scan has to be done, either a CT or an MRI, just to find out what is the real reason for it. Headaches which are increasing on Valsalva, that means somebody is on forced expiration. Headaches that wake you up in the middle of the night, say at 3 a.m. in the morning. So this is typically not migraines. Migraines typically are worse in the late evening, and by the time you wake up in the mornings, the headaches are generally gone. But whenever the headache wakes you up from sleep, that means you wake up at 3 o'clock with a headache, this is generally not a migraine. So these are all the red flags, that can tell us that these are all, some things where we need to investigate, and urgently it has to be seen by a neurologist. So then, as I said, red flags means that they are things which need to be reported early to the doctor. What generally leads to a migraine getting transformed into chronic migraine? And generally, chronic migraine affects as many as 2% of the world population. That's quite high in number, isn't it? So what happens is in people where the headache, the risk factors are not taken away, that is where it leads to a migraine which was say once in a week goes on to become a chronic migraine. So here we have what are the risk factors where it can happen. People who have a genetic tendency, that means their father or mother would have had a headache, would have had migraine in the past. Stressful life events, these are some things which can lead to similar things. Female sex or women are more predisposed to developing chronic migraine. Presence of allodynia, as I said, something where a non-noxious stimulus or a non-painful stimulus gives rise to a painful sensation. People who have comorbid pain syndromes, any other pain disorders, people who have other psychiatric problems. So these are all people who have a higher risk of that this migraine, instead of being once in a week, can become daily headaches. So there are other risks as well. Commonly, other thing that I come to hear people is that people tend to come and tell me that, doctor, whenever I have a coffee, I feel better. But they fail to understand that it's the regular caffeine consumption which is one of the triggers for headaches. And so what happens is it resets the headache cycle, and it also interferes with the sleep pattern, and this leads to headache, which is probably more rebound headaches. Now, something more interesting and something that probably you would not have heard is something called as medication related headache, medication overuse headache. So here what happens is there'll be a lot of people, whenever they have a headache, they go to the medical shop or a pharmacy close to their house, and they go and ask him to dispense medications. They dispense medicines like any over-the-counter prescriptions like that, or any other kind of medicine. So these are tablets. When taken occasionally, it is fine, but whenever it is taken regularly, like somebody has got more frequent headaches and they keep popping this pill without consulting a doctor, so what happens is this leads to a vicious cycle where the next time the headache occurs, it's higher in severity or more intense in severity, and the same medicine, in the same dose, may not be effective for the same person. So then what the person tends to do is he tends to increase the dose. So instead of one tablet, he starts taking two tablets. So one leads to two, and two leads to three. And so this leads to almost daily consumption of painkillers. Now, we all know what happens when we daily consume painkillers. One is, of course, that it leads to gastritis, stomach ulcerations. It can lead to liver function abnormalities. It can lead to kidney troubles as well. It can lead to what is called as interstitial nephritis or nephropathy. So it's very important that these over-the-counter pills should not be taken, and not only for this reason, but also for the other reasons as well. So as I said, this medication overuse leads to a headache, which is called as medication overuse headache. And the treatment for that, you might not believe, is stopping these over-the-counter painkillers, and we just substitute them with some things which are not NSAIDs. That means they are not NSAIDs, non-steroidal anti-inflammatory agents. So we give simple medications, and sometimes we give anti-migraine medications, and we tend to ask the patient to avoid the risk factors, the precipitating agents. So these are all how we say that these medication overuse headaches can be stopped. But please remember, unless the inciting agent or the tablet which the patient has been consuming, unless that is stopped, it can never lead to you can never lead to improvement in symptoms of medication overuse headache. So it's very important to discontinue the medicines. The patient needs to be explained in detail as to what they are doing. So if you are doing it, please understand that it's not good for your health, and you must stop the medicines, consult a neurologist. And there may be some medicines which may be prescribed in the interim, and there are a lot of patients who come back to me, say, after a month or so, and they say, doctor, I stopped the medicine, I felt miserable for a week, but then after that, now I'm completely headache free. So what it means is, because these headaches have been something which is a vicious cycle, and this vicious cycle has been broken by stopping these medicines itself. And that's how we tend to treat this very important condition uh, called as medication overuse headache. Now, for migraine, what do we? So before that, what do we? What are the typical precipitants of migraine? And this is a very common question that people ask me. So alcohol probably and red wine ranks as one of the most common and one of the most significant of the triggers for migraine. Then we can have some of the vegetables like beans. We have chocolates, nuts, cheese, all these, some of the milk products. The Chinese agent, what we call as Ajinomoto, monosodium glutamate. So these are all things which can, uh, which can lead to triggers of migraine. So if you know that this particular food or this particular thing is bringing about an attack of migraine, then I think the best thing to do is to avoid it. And that's the best way in which this comes under control. As I said, the most common things, as I said, is chocolates, cheese, nuts, red wine, alcohol. And it's invariably when you stop the alcohol, it tends to subside. Also, caffeine. As I said, some people may feel that once they take a cup of coffee, the headache is down. But then what happens? For a period of time, this resets your sleep cycle and the headache cycle, and then the headaches become more and more severe, and it becomes more and more difficult to treat. So hence, coffee is certainly not a good thing. And whenever, if you're in a habit of taking coffee, it's always advised that the coffee should be taken uh, before 4 p.m. in the evening, and certainly not after 6 p.m. in the evening, because that can affect your sleep cycle. And apart from that, what else? The other things, as I said, in women is around the cycles, the menstrual cycle period. Then emotional stress, which is common to both sexes. Um, then, as I said, some triggers like physical activity and other things can be there. And lack of sleep is again a trigger which can lead to headache attacks. So as I said, the triggers may be going out in the sun, listening to loud sounds. So these are all triggers which can, if you know that these are things which is worsening your headache, you can always very easily avoid it. And so what are the different agents that we prescribe, in these kind of migraines? So commonly when you have headaches more than 4 or 5 times in a month, your doctor would, after taking a history from you and ascertaining whether this is migraine or not, they will start you on what are called as anti-migraine prophylaxis. So these are, you must understand, there are two basic types. One is the prophylactic agents, and the other is the aborting agents. So what are the prophylactic agents? Prophylactic agents are agents which are meant to gradually reduce the frequency and the severity of the headache attacks. I hope you understand this. So that means if you have about 8 or 10 attacks in a month, firstly, what it tends to do is reduce the frequency of the attacks. So slowly it starts reducing. From 8, it becomes 6, then 4. So it starts reducing the frequency of the attacks. The second thing is the severity of the attacks. So whenever we have the headache attacks which are so severe, say whenever we say it is grade 8 or grade 9 or grade 10 on the visual analog scale, so their headache attacks start becoming less and less severe. That means they are very easily controllable with simple medications. So these are the two things that these anti-migraine medications do to your headache. So commonly you have, as I said, beta blockers, what is called as propranolol. So this is something which can be given once or twice a day, sometimes even thrice daily, and it can be increased sequentially and keeping a watch on the blood pressure and the pulse rate. Apart from that, we have other agents which are calcium channel blockers. There are other agents like anticonvulsants like topiramate and valproate. Commonly used other medications are tricyclic antidepressants, amitriptyline, which is very favored medication for many of the neurologists. So these are all medicines which can have a little bit of sedation. That means whenever we start this medicine, there can be a little bit of sleepiness or sedation in the night, and sometimes early in the morning, the first few doses, and after that it usually tends to settle down. So it's important that whenever these anti-migraine medications are started, it's important to follow these guidelines as to how these medications and how long these medications are to be taken. Commonly what happens is people who come to the clinic, they start very promptly whatever medications I tell them, but then what happens is they take it for about 2 weeks or 3 weeks, and then they feel very good and they stop the tablets. And then what happens is they wait and wait for 2 weeks, and then again when it comes back and becomes more severe than what it used to be, they come back again, and now it becomes even more difficult to treat. So it's important to remember that most headaches or migraines, the treatment, we tend to give it for about 3 to 6 months, sometimes longer, sometimes shorter, depending upon somebody's symptoms. And so these are medication choices which are again arbitrary. It depends on the patient profile, and also the comfort of the prescribing neurologist. For example, if somebody is obese young lady or obese middle-aged lady, who has no visual symptoms, who has no kidney stones or any history in the past, I might prefer topiramate as a good choice. While in somebody who has got a lot of stress, anxiety, and other psychiatric symptoms, I would probably go with amitriptyline as a choice. Somebody who has got coexistent seizure disorder, somebody who's got fits in the family, or somebody who has fits in the past, so in them I might consider either topiramate or valproate. So it's important to understand each of these medicines can have some side effects, and which have to be educated and to be told to the patients, and you must be aware of these side effects, and accordingly these medications, if there are any side effects, it needs to be reported to the physician. So apart from these medications, is there any other form of therapy that can be done, or that can improve these kind of headaches? Well, there are amongst all these things, as I already spoke about, so apart from the pharmacological agents, so there are other things which are used when there is the headache becomes more refractory or becomes more severe. So in that, there's something called as Botox or botulinum toxin, and generally this you must have heard about it, which is got cosmetic indications. It can be injected in the muscles around the scalp region, in the muscles at the back of the head and the neck. So this leads to resolution of symptoms in people who are not very conducive or who do not respond so well to these kind of medications. Then apart from this, then we have something called as nerve blocks, or interventional procedures where you have a occipital nerve block. You can have auriculotemporal nerve block. So it depends upon which nerve, and what we generally inject is lidocaine or bupivacaine, either with or without steroids. So an anesthetic agent with or without steroids is injected in that particular nerve distribution. So this is called as interventional therapy. And along with this, there are other therapies which are holding promise for the future. Some of them are what we call as CGRP antagonists. One of them is called as erunumab. It is still not entered the Indian market, deemed to be very expensive. We still don't know the cost as yet, but has got a good resolution of headache attacks. Not dramatic, but slightly better than what these medications tend to provide us. So as I said, apart from Botox, I told you about interventional therapies. I told you about nerve. Then there's something called as occipital nerve stimulations. So all these things can be done in people who have a refractory headache. That means even with one or two or sometimes three medications, if the headaches are not coming under control, this is something which can be tried, and most times with very good results. Along with this, conditioning them, giving them good behavior and physical therapy, relaxation training, thermal biofeedback, and cognitive behavioral therapy. These are all things which help in the patient understanding his symptoms, and it helps in him relaxing. And it's very important that we understand that these episodic headache attacks, when not treated adequately, can become chronic migraine, and which become more difficult to treat. So hence, these things have to be identified uh, pretty early. So what are the tips which I would like to give for patients who have migraine? So please avoid headache triggers. That means if you know that these are the food items, if you know that these are the triggers, please avoid taking that or getting exposed to it. Avoid medication overuse. It's very important. So please do not take over-the-counter medicines for more than twice a week or more frequency. Get enough sleep. At least 7 to 8 hours of sleep is very important. Do not skip meals. So fasting is again something very, very important. So fasting can invariably lead to a migraine. Exercise regularly. So increase physical activity, reducing stress. Meditation and pranayama are supposed to be very, very good for migraine, and reducing the caffeine and alcohol. So these are all things which are simple tips, and can lead to remarkable improvement in the symptoms of migraine. Now, there's something very peculiar which I think a lot of the IT employees can do complain of. This is something called as CVS, or computer vision syndrome. So generally, they tend to have a strained feeling in their eyes when they are sitting in front of the computer screen, and it can affect as many as about 60 to 80% of the people. The condition does not cause any permanent eye problems, but then it can lead to a lot of eye strain. It can lead to redness, irritation, burning feeling. Sometimes it can lead to a blurred vision, and sometimes there can be a lot of neck pains, backaches, headaches, and all that associated with it. So what needs to be done? Usually one of the reasons where it happens is because of uncorrected vision problems, the dry eyes, poor lighting or a bad posture, all these things, and the distance from the monitor. So these are all things which can lead to this peculiar condition. Sometimes another thing that is probably not treated well is the refractive error. Somebody has got a refractive error. That means they have a glass number and that number, the person is not using it. So that also can lead to this thing called as computer vision syndrome. Then what are the remedies for it? So one very important thing is try to find out if there is any if there's any refractive error. So go to an ophthalmologist, get your eyes checked, and see if there is any number or refractive error, and that needs to be promptly corrected. Second thing is the screen should be at least an arm length away from your face, and at least it should be comfortably placed so that its center is about 4 to 8 inches below the eye lines. It should not be above the eyes. Follow a good posture. It should reduce the strain on the neck and the back. And most importantly, there should be adequate lighting all around, and it should not be a very dimly lit room. And we should reduce the glare, use anti-glare, the screen as much as possible. And there's something called as computer glasses as well nowadays. And whenever refractive error is there, it has to be treated. And avoid prolonged exposure to in front of the lights. And this helps in, just get up after about, say, 20 minutes or 30 minutes, just take a walk down, breathe fresh air, and then come back and sit. This avoids your continuous exposure, occurring all the time. So this was about some of the common things that plague us uh, in today's time, and things which we need to be aware of. Well, talking about the entire neurological things is beyond the scope of this today's discussion, but I would like to hope that everybody, you and your dear ones, are all safe and healthy at this point of time. And please follow the social distancing, the usage of the mask, the sanitization, and all other things which has been told. And please protect yourself and your family from what is happening today. It's very important to keep yourself healthy and safe, and not become a victim of this virus. The other thing towards the end, I would just like to cover just one important aspect of what are the COVID related neurological manifestations, and why it's important, because it's very important. A lot of patients may not have a fever or running nose or flu like symptoms, and sometimes neurological presentation might be the first presentation of COVID. And this is what makes us, the doctor fraternity, very, very vulnerable to this, because we do not have symptoms. That means the patient who's coming or walking into a room doesn't have the symptoms at all. But uh, then slowly what happens is he presents with one of the complications, which is a neurological complication. And then either it's tested randomly, or when it is tested for some other reason, he turns out to be positive. So this is something which can be a real threat in today's time. So what are the neurological manifestations? Usually it is, most of the times it's inflammation mediated, which is headache, which can lead to altered consciousness, can lead to delirium, where there can be some autonomic disturbances, altered behavior, altered mental status, and sleep rhythm can be disturbed. It can lead to strokes, and sometimes stroke may be the first presentation of COVID. So it's very important to, whenever we have in this today's time of COVID, somebody presents with stroke, and more so somebody young presenting with stroke, we need to keep our eyes open for something which is neurological manifestation of COVID. Apart from that, we can have meningoencephalitis, where somebody may present with headaches, gradually progressive decreased consciousness, and seizures or fits. Meningitis or meningoencephalitis is what we call it. So apart from this, you can have people who present with anosmia. That means they don't have sensitivity to smell. They don't have sensitivity to taste. It's called as ageusia. They can have acute myelitis. That means they can have a swelling in the spinal cord, leading to paraplegia or weakness of both the legs, sometimes associated with numbness below the waist or below the neck, sometimes associated with urinary disturbances. All of this can happen if there's a acute myelitis or a swelling in the spinal cord region. Another very common thing that it causes is what we call as Chibi syndrome. So our peripheral nerves, which go to our hands and legs, can be suddenly affected, and they can get swollen. This is called as AIDP, inflammatory polyneuropathy. And this can lead to weakness, which can progress over days to 2 to 3 weeks, and it can lead to complete weakness as well. And this weakness is usually element type. It leads to weakness of hands and legs. Sometimes, rarely, it can lead to even difficulty in swallowing. It can lead to difficulty breathing. Sometimes patients requiring ventilatory assistance as well. So it is not that all of these patients present with these symptoms, but in today's time, we must know what are the COVID related manifestations, so that we effectively understand and refer them, and so that you're also well protected. You and your family is well protected from it. So with these few things, I hope that this session was useful to you all, and I hope that you follow the safety norms, and stay healthy and stay safe. Hope both you and your family remain safe during these troubled times, and hope that this epidemic also dies down very soon. And it's always better to have more face-to-face interactions than something on video or on webcam. So thank you, everyone.